When a patient enters a psychiatric intake, the clinician is immediately hit with a wall of chaotic, overlapping data points. To make sense of that noise, the provider captures a cross-sectional snapshot of the patient's mind at one discrete moment in time. This diagram shows the dense overlap of possible psychiatric diagnoses. The Mental Status Examination, or MSE, provides the toolset to navigate this cluster. The exam moves beyond a passive observational checklist or a simple inventory of the pathology a patient happens to display. The MSE provides a rigorous filtration engine designed for diagnostic exclusion. Specific categories of psychiatric illness are systematically deleted from the differential as the clinician identifies negative data points. This deletion process relies on the pertinent negative. While a positive finding is a symptom the patient currently experiences, a pertinent negative is a high-yield symptom the clinician verifies the patient does not exhibit. In the diagnostic matrix, the confirmed absence of a symptom carries the same structural weight as its presence. Utilizing these pertinent negatives allows the provider to narrow a differential diagnosis, shifting from a passive observer to an active diagnostician. Capturing a complete snapshot without missing critical details requires a rigid, systematic framework. This dashboard illustrates the modern MSE architecture, built on 16 distinct clinical domains divided into 4 sequential categories. It begins with observation, where the clinician evaluates appearance, behavior, consciousness, and psychomotor activity. Next is output, focusing the assessment on the patient's speech, mood, and affect. Establishing these physiological and observational baselines is a prerequisite for deeper analysis. A clinician cannot reliably assess cognition if the patient's basic arousal networks are compromised. Once the baseline is secure, the exam moves into cognition and processing, assessing thought process, thought content, perception, and general cognition. The sequence concludes with the higher order and disposition category, evaluating insight, judgment, impulse control, reliability, and safety. These domains follow a strict hierarchical dependency. If delirium clouds consciousness in Step 1, impaired insight in Step 4 is a symptom of that delirium, rather than a separate psychological failure. Moving through this 16-domain pipeline ensures a comprehensive evaluation, forming the structural foundation required for the diagnostic exclusion process. This framework moves from the abstract into the active, high-stakes application required within a chaotic and unpredictable clinical environment. Consider a patient who arrives at the intake desk presenting with severe, undifferentiated agitation. This decision tree maps out DSM-5-TR syndromes. The clinician must immediately evaluate the high-risk suspicion of an acute manic episode. The patient exhibits an elevated mood. This positive observational input keeps the pathway to a mania diagnosis active. The clinician then examines the output domains and identifies a pertinent negative. The patient exhibits no pressured speech. This negative finding serves as a categorical blocker, reducing the probability of the mania hypothesis. In the cognition domains, the clinician identifies a second pertinent negative. There is no flight of ideas. The cumulative weight of these pertinent negatives severs the diagnostic pathway to mania. The clinician reduces diagnostic probability through the logic of documented exclusions rather than relying on instinct. This documented exclusion pivots the clinical focus toward alternative etiologies, such as a substance-induced state or an acute trauma response. Rigorous documentation of what is not occurring prevents misdiagnosis and directs critical acute medical resources more effectively. Beyond diagnostic categorization, the intake process must facilitate immediate triage and risk assessment. To achieve this, we isolate the final domains of the matrix: impulse control, judgment, and safety. The safety domain requires an aggressive assessment for suicidal intent. The clinician must simultaneously assess for homicidal ideation. Both parameters are verified as negative findings and documented accordingly. Explicitly documenting these specific negative safety parameters is necessary to address clinical danger and manage legal liability. These verified negative findings build the case for a specific outcome, a routine outpatient disposition. These negative inputs provide the evidence required to justify avoiding involuntary psychiatric holds or emergent interventions. The safety matrix leverages pertinent negatives to establish a verifiable, legally sound baseline for patient disposition. This completed dashboard represents the full cross-sectional analysis for a single patient profile. The positive findings provide the initial clinical context. The negative findings then lock in a specific, narrow differential diagnosis. Clinical accuracy relies on the deliberate tension between positive symptoms and documented exclusions. Precision in psychiatry requires identifying the specific symptoms the patient lacks with the same rigor used to identify pathology. The mental status examination provides the structural logic for building accurate, safe, and defensible psychiatric diagnoses.